Good. Good morning. My name's Paul Bollinger. I'm with Health Share of Oregon, and I'll explain a little bit about what Health Share is because probably no one here knows because it only happens in the state of Oregon. So we'll go ahead and hop in. I'll also introduce my colleagues, but kind of want to start off with the opening line for a bad joke. So a regulator, an educator, and a payer walk into a room and want to create a data set for community paramedicine. So this is our story. And that didn't do it. No. There we go. Okay, state of Oregon, in case you forgot where we're just below the state of Washington, just above California. Yes, we're always above California. Quick pop culture question. Anyone seen the show Portlandia? Okay, well, we live it every day. So we're based in Portland, Oregon, home of the Portland Timbers, Mount Hood. But the big thing saying around Portland is keep Portland weird. And what we do in healthcare in Portland and in the state of Oregon is a bit weird. There was a small thing that a few of you may have heard of called the Affordable Care Act a few years ago. Well, a lot of money was infused into the state of Oregon, and we have what's called the Great Experiment going on around how to improve healthcare delivery system in our state and at our local communities. So put a bird on it for those of you that obscure Portlandia reference. Okay, so before the Affordable Care Act or the ACA or Obamacare, healthcare in Oregon was a big empty puzzle pieces. There was your dental care organizations and your mental health organizations, medical care, and your labs and your dentists and hospitals and everything were all mixed together. And the people that really suffered the most were the indigent population. And the group that I work with works with our Medicaid population, which is a government-funded way of providing health care. So what we were able to do is take that whole mess, convert it all up into what's called a coordinated care organization. And coordinated care organizations are using the Medicaid money at the federal level, which used to be state administered, is now administered at the local level. So in the state of Oregon, there's 16 coordinated care organizations serving the Medicaid population. And we're now looking at the member experience from a very local perspective. So what you see in the Portland area is going to be really different than happens in the southern or eastern parts of the state. So we had to really look at what healthcare transformation was going to be different, and could we do more with less? Can we do more of what really works for our own community? Can we let go of stuff? Is that even possible in healthcare? And how are we going to really improve the quality of life for Oregonians? So we kind of are taking two different approaches with that. Is change the delivery system, look at auxiliary providers, look at other ways of delivering healthcare, and really look at what healthcare's relationship is to the community resources that are available. So back in October of 2014, HealthShare represents about 240,000 members that are on Medicaid. So we administer the Medicaid benefit of health, physical, mental, dental care, and non-medical transportation. So in spring of 2014, HealthShare decided, you know, EMS hasn't played a real big role in this. Let's get everyone together. And we kind of put an all call out saying, if you're interested in this, come to a hotel room similar to this, and let's talk. Well, we had 200 people show up, and it was the payer community, public health, the regulators, the other CCOs in the area, and EMS providers. And this is the first time a lot of these folks had a table-to-table talk, to have leaders in the payer community and the health systems to really say, wow, you are more than just a transport organization. You are a clinical extension to the work that we do. So flash forward to where we are now. We have a real active coalition. We have about 14 different community paramedicine sites statewide, and as you'll see, each of the stars represents one of our sites. Interstate 5, which is the large north-south freeway system that runs from the Mexican border to the Canadian border, runs along the western corner of our state. 80% of our population lives within 10 to 20 kilometers of Interstate 5. So that's why there's a big concentration of community paramedicine programs kind of along that one line. Up in the northern part of the state is where Portland is located. There's 3 counties there, and we have about 6 different programs there. serving about 1.3 million people in the population. But many of you that are from Australia, Canada, and the UK are fortunate that you don't work in the healthcare system that we work in. Just to give you a snapshot of what it's like in the 3 counties, we have 21 different fire departments, 2 primary ambulance contractors, 2 coordinated care organizations, 4 911 answering points, and 1.5 million people. So trying to get, and then I forgot about the countless insurance schemes that we have going on in the Oregon area. So trying to get these folks to play nice in the sandbox has been a challenge at best. So, but it's working, and it's been amazing that we were able to finally get folks together around community paramedicine to say this is really a betterment for our community and really looking at existing resource pools. So these are some of our initial groups that we worked with. We were able to work cross-border with the state of Washington also. So we have, Portland's right on the Columbia River, and across the river is the state of Washington. So we've pulled Washington in, but we've had the county health services, other CCOs, the fire departments, ambulance providers, academia. So we got a really well-rounded representation that is our kind of core community paramedicine group in our community.
So we started making discussions and having a monthly discussion meeting between all of the organizations that Paul just described. We had payers, we had regulators, and we had academia, myself. We started hearing a frequent theme coming through the discussions that we were having, and that theme was that we were being able to find money for pilots, and those pilots were funding those small agencies to do community paramedicine in limited capacity, and we're finding N values of 25, 9, maybe 30, 45 at a time. Some of you Canadians have presented 2,000 case studies. So we're really struggling with small N's, and when we demonstrate success with our small pilot studies, we're going back to the payers and saying, hey, we demonstrated great success, we saved all this money, we made this great impact on patients' lives, and they're not ready to write $1 million check off of 45 people. Reasonably so. So we started asking the question, how do we fix this? Because we're not going to get the money infused to one organization to be able to provide an N value large enough to create the return on investment for funding, for long-term investment. So we decided to do something. And this is building off of several presentations from yesterday and today. We decided to start burning down some of our silos and collaborating on some of the data points that we were already collecting. What we needed was big data to funnel into our AAA to increase the value of our service, to improve the system quality of care, improve our resource allocation, and to overall improve health outcomes. And like I said, we're burning down those silos, and we were able to get 20 people in the same room representing 10 different organizations from EMS, fire, regulation, academia, payers, to discuss what data points are we currently collecting, what data points are we collecting that are the same, and then also have a discussion of what we should also collect. What questions do we want our data set to be able to answer? Questions of return on investment, questions of quality improvement, and quality assurance. And started gathering around from the nation, from the folks that have been doing community paramedicine a little bit longer than us, started asking them, would you share what data points you're currently collecting? So we could start compiling a list of data points that we're already mostly collecting so that we can help to prove this return on investment. So our timeline started in October, and we're moving our way through until current. The process has gone through a few analytic reviews with data analytic support from our payer systems and Health Share of Oregon. We've cross-mapped our data points to the NEMSIS database, and for the folks that are from Canada or Australia or UK, that NEMSIS system is the national database for the 911 side on emergency response. We've also coordinated with other databases to collect data points that we want to include into our data set. We've talked to data analytics to make sure that our data fields and our acceptable responses are narrow and not free text. When we try to pull free text data, you can't do that, and it takes way too much time. When we developed this system, we had this big list of data points, and we said, okay, great, now how do we operationalize this? And operationalizing is the challenge, because in EMS, we hate charting. At least in our neck of the woods, EMS is not great on creating patient care reports and following through on quality charting. So we wanted to see how long is this going to take to do. So we built a beta front end to see how long does it take to go from patient encounter all the way through to the end of the chart. And so this beta testing took around, for the initial user, took 20 minutes to complete, and on subsequent, the time decreased. So we're looking right around the 10 to 15 minute mark for an experienced user of the beta front end. So continually, data analytics has been involved in our process to make sure that what we're collecting is actually going to answer the questions that we want it to answer. And furthermore, we're getting involved with the health informatics team at Oregon Tech, and Oregon Tech is the university that I represent. We're an engineering college that also does paramedicine and EMS education. And that health informatics team is led by senior student projects. So at this point, we have spent no money on this. This has all been a grassroots organization from in-kind donations, and we're creating the process as we go here. So into the future, eventually this is going to cost money. It hasn't cost a dime yet, but it will. And in the future, we're going to need some support from our regulators and from our other agencies and our partnering organizations to continue this process and to continue to provide the large end value that we really need to be able to prove the return on investment. So what? We've talked about a few things. We've talked about we need a return on investment. This data set will also help prove quality assurance, quality improvement, and it'll help set the standard of care for organizations currently doing community paramedicine, as well as organizations seeking to do community paramedicine into the future.
So the next steps, right? My name is Louisa, I'm from the government, and I'm here to help. And one of the exciting things about this project is the potential for the big data that's going to come out of that. One of the things that we really, really need is, the ends of 3, the ends of 14, the ends of 30 are great. And I think we've actually shown some really great efficacy with community paramedicine through those small ends. And part of that is because of what's going on globally. You guys have a lot of the big ends in Canada and Australia. We have multiple small ends across the state and all across the US. And combined, I think we've already shown that there's efficacy in community paramedicine. The cat's out of the bag. I don't think we're walking back 10 years to do something different. So I think the payers are actually coming to us and saying, we want more, but we've got to have the big data to do that. And what we see across, especially in Oregon in that Tri-County area, is the big hand that community paramedicine has had on population health. EMS has had one foot in public safety, one foot in public health for decades. But what we really see, and where I think we're really showing a lot of great potential, is in that population health and how we impact the communities around us. The unfortunate thing is right now our payers that are really coming to us are looking at the indigent population and saying, we want the at-risk community to really be affected by community paramedicine. But with big data, what we're really able to do is not just hit these triple aims for the indigent population, for those that are only serviced at the government level in the US, but we're actually able to service everybody. We can use big data to show that community paramedicine isn't just an EMS transport, it's a medical service for everyone. And so as the regulator in the room, what I want big data to do is to drive that process forward to serve my entire community, not just the homeless, not just the uninsured, not just those that are at risk. And so we're looking for that big data to push those processes forward. I'm really excited to hear what CSA was doing in the standards process that's going on in Toronto. We're going to be watching you guys in that process because we want to be able to mirror some of those processes back at home. And one of the hard things that, as a regulator, that I know that you all have probably witnessed as well, is that In that transformation of EMS over the decades, if you see one EMS system, you see one EMS system. And for us, we're kind of throwing a stake in the ground and saying we don't want community paramedicine to be that in the United States. We don't want it to just be one little tiny program. We want it to have these tentacles kind of that reach out to everyone and grab hold of everyone. I used to teach in the community colleges years ago, and I remember having a conversation, this is probably about 15 years ago, with one of my administrators and just saying, you know, EMS needs to grow up. EMS really needs to stick its neck out there and do something really transformational. And what's really exciting for me is that, you know, 15 years later, we're watching EMS grow up. We're watching EMS really mature and be what I think it really should be designed to be. And that's, of course, not just transport, and it's not just treatment, but it's prevention also. So thank you so much for being here. We appreciate your attention, and our contact information is here if you have any questions. We'd be happy to talk about the data set with you some more.